YouTube's on. We're on. We're off and ready. So good morning, everybody. Welcome to the Adult Social Care Health Select Committee. And I'll ask if there's any apologies for absence, please. Oh no, sorry. I'll ask for the minutes, please, to be approved. The minutes of the last meeting. All those in favour? Thank you very much. I'll sign the minutes. And do we have any apologies for absence?
No apologies, but just note that there has been a change of the membership of the committee with Councillor Karen Bailey replacing Councillor
Tom Smith.
Sorry.
And he's on his way because I've spoken to him. He's stuck in traffic. Yeah. Okay. No other declarations of interest?
Chairman, can I just go back to the last item? Just for accuracy for the record, I'll be substituting for Councillor Barney this morning.
Okay. Thank you, Scott. Yes. If any council or officer has an interest in any matter on the agenda, you should declare it now. Please raise your hand, and if you have an interest to declare, you should state what type of interest it is and give brief details. Has anybody got any matters of interest to declare? No. Thank you. Okay, so we'll move on to our agenda item 4, and I would like to invite Scott McKechnie, the independent chair of Nottinghamshire Safeguarding Adults Board, to introduce the report on Nottinghamshire Safeguarding Adult Board meeting, strategic priorities 22-23. Thanks, Scott.
Thank you. Good morning, everyone. As I said, I'm Scott McKechnie. I'm the independent chair of Nottingham Safeguarding Adults Board. I'm here to present on the Safeguarding Adults Board yearly report, annual report. So I've got some slides that I've shared in advance to share. So hopefully we'll be able to see them okay. So firstly, I think it's important to sort of raise right at the start of this annual report presentation today just some of the challenges that are faced across the sector at the moment in relation to safeguarding adults and other wider issues, particularly around the sort of financial challenges. It's something that we hear of at the board, but also the workforce challenges and that cost of living challenge that's impacting on our communities, as you all know. So that is part of the context of this adults board. What we hear on a regular basis is about those financial challenges, but we still, as in the first slide here, have a duty, statutory duty from the Safeguarding Adults Board, and you will see on there the 3 main duties of the board. Is to have a strategic plan, and our strategic plan still has the 3 pillars under prevention, assurance and engagement. And one of the key factors in what we do as a board is to analyse data on safeguarding notifications to understand the profile of abuse and neglect locally, reviews local safeguarding arrangements and develop mechanisms to hold partners to account and gain assurance. Safeguarding adults review at point 2 there are undertaken, so we have a system in place where any severe abuse or neglect is reviewed and a decision made whether to have a formal safeguarding adult review under the Care Act. And then the final thing is annual report, what I'm here for today. But one of the key things around that is about working collaboratively to prevent abuse and neglect. A key function of the board is also to develop policies, guidance for protecting adults, which is shaped by the statutory partners, but also the views of adults with lived experience, families, advocates and carers. And then ensuring that one of the key final aspects is about ensuring that we, as a multi-agency group, have that learning and policy development process in place so that we can improve practice and quality of the life of adults in the area. So I'll move on one slide, hopefully that will move. So into one of the key aspects, which is analysing the data. This is part of the report, page 14, 13 and 14. What you'll see there in the top box is an overall reduction, 660 less concerns received regarding safeguarding adults referrals in 22-23. This is actually slightly out of sync with the 9% increase nationally. And what that's translated into, and you'll read in the report, is of those 9,090, 7,720 were dealt with at the concern stage. So that's within the MASH, the opened and closed end-to-end process within the MASH, the Multi-Agency Safeguarding Hub, which is a reduction of 3,775 less referrals moving out into the district teams. So that's seen 1,370 moving to district teams. So that was part of a review which was commissioned by the Director of Adult Services. Apologies, something popped up on my screen there. Melanie may want to come in later on, but they've reviewed how the process works within the MASH. More work is being dealt with end to end within the MASH, which is putting less pressure on the district teams to allow them to focus on the quality of the safeguarding adult work that they do. You'll see in the report as well, page 14, there's a mention of the data accuracy improvements that are ongoing. So we're driving overall in the adults board just to understand the data better, provide that quantitative analysis of what's going on, to give us a profile of that picture, but also how that's recorded within the system so that we can accurately present details of what safeguarding adults data is showing us. So there's an upgrade to a system called Mosaic, which is taking place in adult social care.
Thank you. Do you want questions now, or going through the report, or at the end?
Whatever you feel. Yeah, you can. I'm really relaxed. Yeah, go for it.
Yes, thank you, Scott. So on the graph you've got the annual move in total numbers of concerns raised, and then down below an analysis of the types of abuse raised. Do you have any information on which of those types moved up or down over that period? So were there anything significantly different from the general downturn?
So those three, which are neglect and acts of omission, organisational abuse and physical abuse, have been the same three top previous years, which is also in line with the national average as well. So those three areas of abuse remain the same as previous years, but also in line with what's happening elsewhere nationally. So that's actually covered that part of the next presentation off, so I'll move on to the next slide. Location abuse, again, what you'll see here from the report, that also remains the same as previous years, and also in line with the national picture around where the abuse is taking place. One of the things that we've focused on this year, I took over as the chair last year in November, but one of the things that I'm really keen to develop as a board is how we monitor the data, and the quality assurance subgroup have reviewed the data sets that are now monitoring coming in on a monthly basis and through into the board and the executive, but also have spotlights from different organisations on their own data. So police presented, fire service presented on those spotlights, but also then moving now into that to where we're going to be conducting more audits. So we will probably have more of that next year and next year's annual review, some more detail around that. But that's the picture of location of abuse. And then finally, for the slides, that is the statutory duties. So one of our key statutory duties is having safeguarding adults reviews. So you'll see there K19 and L20 were both reviews that were commissioned in previous years. That those action plans are still working their way through the board to ensure implementation. And then this year, during this annual review year, we've commissioned 3 new safeguarding adults reviews. You'll see there M22, which involved a male with physical disabilities and complex care needs, who had a young carer. That's focused on the support provided to that carer on this difficult journey. N22 is through inclusion of the rough sleeper initiative in the board process and subgroups, led to a case being heard outlining the challenges in the homeless man accessing accommodation due to substance and alcohol misuse. And then the final one is jointly commissioned with the Children's Board, our partnership, and looks at a case of female with care and support needs transition to adult services and how a system, trauma-informed practices were used to shape services around that young person. So those SARs are currently underway for publication during this, we would hope publication during this yearly report cycle. Also took place something that Melanie was heavily involved in with the ADAS network, East Midlands Regional Safeguarding Assurance. A review was conducted around 2 SARs by the region, commissioned by ADAS, and involving 6 other adults boards, and the feedback provided was good, that we provided a good and varied offer of learning to partners following recommendations coming out of reviews. So I'll stop sharing my slides. Let's get some other key highlights to raise that are in the report. So some of the other key either changes or impact. So we, following a review that was commissioned before I arrived, we've reviewed the governance of the board and introduced a executive group which is made up of the 3 statutory partners, so police, health, ICB and social care, adult social care, and subgroup chairs, which gives us a layered approach where that meeting takes place in between the main board, which allows that, facilitates a good forum upon which we can discuss business plan in detail, priorities in detail, and any tricky issues that are coming up. Big part of what we spoke about earlier around prevention and engagement is around, we've enhanced the offer that our communication subgroup can provide to the board, and that's about now, particularly this year, delivering a new comms strategy across the county, looking at both professional networks but also the out into our communities. We've reviewed the membership of the board, and we will continue to do that every year, at the start of every year, to make sure we have got the right partners there in addition to the statutory partners. So during this annual report year, Serco, Prison Service, the Diocese and National Rehab Centre have joined us. It's not in the report this year, but they're going to be joining the CQC, have joined the board. So we're constantly looking to make sure that we have got the right partners with us in the board to tackle what are the issues that are here and now. Next part of page 10 of the report, you'll see a mention on a review, and I've previously discussed this with this committee previously in June, I think it was, about a review. So the board asked the ICB to work with us on the review following the Panorama show last year on the Evenfield, but also has reflections back to what happened at Winterbourne View as well, and other establishments that have that sort of close culture, and it crosses over into the children's world as well on occasions. So we now have worked through a task and finish group with that. Now we're now moving on to an action plan which was presented to the board in the springtime. Some of the key areas which again we will bring forward and make sure that are implemented is around a provider collaborative, which the ICB are leading on. That whistleblowing process, and make sure we're triangulating information both locally with CQC, and then we're also going to be commissioning an advisory advocacy review of culture and the voice of people who live in those and their families, just to get some idea of what the culture is. That's work that's ongoing now. As I said, mentioned earlier about a little rough sleeper initiative. We have got good links now across into that rough sleeping initiative. The coordinator for rough sleeping, coordinator for the county, sits on our Safeguard Adults Review subgroup, but also the Learning Development subgroup. That's been really influential, in particular around understanding the difficulty in engaging people who are in those difficult situations, and the patience and time that's required. And we've managed to use someone who's had lived experience of that to enhance the training offer that is provided around difficulty engaging. One of the key aspects of the board moving forward, and we started this work during the annual report, was about the voice of lived experience, and in particular we have now got, was implemented at the start of this year, a task and finish group around co-production of those of people who've got lived experience of the safeguarding system. And the executive have been quite clear that they want to be ambitious about that work, and we recently had during the Safeguarding Adults Week a workshop focused on co-production, just in how can we enhance the great work that's already going on in the local authority alongside what has been developed in the NHS to focused on in particular safeguarding adults, but also the voice of their families, the carers, and how that impacts on the community. And the final thing I think I'll raise, just I think I previously presented this in June, but it's mentioned in the report, is the work we did around the assurance work we did around Circle with asylum seekers and refugees, in particular looking at what systems and processes they have in place, what training they have in place, how they're monitoring potential safeguarding concerns that are coming out of those establishments. So that's been a really healthy dialogue with them, and I'd also I actually visited one of the sites with the board manager to understand firsthand myself just some of what was getting spoken about, what some of the processes were in place, and I spoke to some of the members of staff there. So, and Serco are now providing information to us and have presented at the board some of the data around that, but we know that's a constant changing picture in any case. So that's the main things I think from the report, is to present the comments and the annual report to the board, and I think we were proposing that this would be an annual update rather than more than that in between, unless the committee feels otherwise.
Thank you very much for that, Scott. Any other officers got anything to a portfolio, anything to add? Melanie.
So just briefly, obviously Scott joined us as independent chair 12 months ago, almost to this day, isn't it, Scott, actually, when I think about it. And part of that was Scott's role was to review the interagency governance arrangements, to look at how we could improve that and get the buy-in. So it's really good to see that progress in the report about the broader sector engagement. And we spent a lot of time making sure that the statutory partners are well represented and clear about their duties. So I think it's good to see in the report that the governance has improved, and I think I would echo the requirement for an annual report back to select committee in terms of reviewing the previous year with the report looking backwards, and then the objectives for the following year would be my recommendation.
Yes, thank you for that. And probably look with the benchmarking on previous years on some of the figures, so we know whether we are performing better or worse than the thing, which is good. Yeah, no, thank you, Scott. No, I got from your report where obviously the MASH is really working well for you by sort of sorting out some of the inquiries that you get and then filtering them through so you don't get things, which is really good and helps on that way. But I did just wonder, we know now that unfortunately the City Council are under great financial pressure and they have a lot of safeguarding issues and rough sleepers. Do we get an overspill? Would you worry about an overspill from that, or is it totally ring-fenced to two things in groups?
I'll probably pass that question on to Melanie in terms of the overspill, but in terms of the MASH, I think I didn't mention during my presentation, but I've also personally been there to provide a bit, part of my role is to provide some scrutiny as well. So I've been to the MASH on 2 occasions, one very recently, to make sure that those process changes are understood and are working, and I was very reassured recently, and the system change that I mentioned will enhance that. But we having gone at this time last year and having gone this year, you can see how the culture and the processes had been embedded and well understood in that year, and that's obviously reflected in the data. But in terms of that overspill, I'll pass that to Melanie.
So the duties of the city to safeguard their residents would be really clear. So that's clearly defined for my duty and the city's duty. So I don't have any concern they're not delivering that. In terms of the specific question, Chair, about rough sleeping, we have some work that so it's slightly out of scope of the Safeguarding Adults Board, but we do try to work collaboratively across the county on that agenda. So within public health, we work closely with the city on sharing the approach to housing and homelessness, and we're actually meeting early today about some of the work we've got across the district of borough councils and ourselves to try and have a sort of broader perspective about homelessness. Like I say, slightly out of scope of Safeguarding Adults Board, but I don't have concerns about overspill in terms of MASH activity.
Okay, thank you for that. I'll open this up to members for debate. Councillor Doddy.
Hey, thanks very much. I thought it was a lovely presented report, nice and easy to read, and enough graphics, etc., to be able to pick up on the trends. I was looking at the various types of abuse, etc., and not surprisingly, most of it occurring in people's own homes. I was wondering, has technology led to any increase in the picking up or reporting on these things through intruder sensitization monitors in people's houses? Have we in any way moved towards a way of looking at who comes and goes from vulnerable people's houses through technology to improve the pickup rate, the speed at which we pick it up at, or is that still in its infancy, or has it got nothing to do with it? So I was quite interested from that point of view. When you flick over the page and look at who's actually carrying out the abuse, most abuse is obviously always carried out by people who are close to the person, etc. But it's a shockingly big figure at 604 of somebody unknown to the person. And I just wonder what sort of data we had on who are the unknowns. Where did they come from? Is this the milkman? Is this the postman? Who are the unknowns? And do we know the unknowns? How can we make them knowns in order to reduce it as we go forward? So that's just what I was particularly interested in. And is there any suggestion that we're actually picking up abuse earlier, showing progress in the improvement in which we're actually picking it up, as opposed to it when it's actually reported? In other words, there's abuse going on for a day, a week, a month. Are we getting any better at picking it up earlier? Thanks.
So I think it was 3 questions there. The first one was that technology was I'm not aware of that, but Melanie, again, in terms of that practice, if that's the sort of thing that's very much focused on sort of the practice side of things. In terms of someone unknown to the person, yeah, it's a shocking figure. That's been a consistent position for some years now, and yeah, you know, I don't know how we can answer that. It's something that it's a good question, and we can go away and look at that and actually look at the data to see if we can get a profile of why that is unknown, unless Melanie knows more, because this data gets analysed in detail through adult social care as well. So, but there will be examples of that. And the final question was around. Yes, yeah.
Intervening earlier in problems.
Yeah, so that would always be the ambition. I have to say at the board, hence we have that sort of prevention arm of our strategy. Whether we're actually doing that or not, I don't think we could ever be completely clear around that, because often prevention is not, you can't really measure prevention, but that's always the intention, and all the statutory partners, when they're going to any situation where there might be any chance of neglect or abuse, then they're always looking for that. And we had a presentation from the fire service actually about that, and how they are very much on that prevention arm. And a lot of those concerns that are coming into the MASH will come from that wider partnership around, they've gone to the ambulance service, have been called out to a care home, they've raised a concern, and then they refer in. Likewise, fire service, do some really good work around that with our Charlie P programme that presented to the board around that prevention and trying to prevent the potential abuse. And I think the Charlie P one was a really good example that was presented this year. It'll be in the yearly report next year, but about how if a social worker, a care worker can make a referral to the fire service because somebody who's vulnerable living in an address doesn't have any smoke alarms, then the fire service will then deploy and do that sort of prevention activity and install smoke alarms in the wrong person's address. So there are systems in there to help the prevention. Whether we're actually getting there, I don't know. Melanie might offer a professional view, both from a regional sort of national level as well. Yes. Yeah.
You couldn't hear me? No. Yeah, well, you see, you must have magical powers, Councillor Carr. It's been said.
Sorry, Melanie.
Yes, if you have an interest in the unknowns, we can provide some information. But some of the groups that we would know would be, for example, scamming. So people that draw upon care and support are much more likely to be scammed and respond to scams. So we do some really close work in with trading standards, for example, and we also do some protective work, which is about trying to support people with care and support needs to understand the danger signs. But they are more vulnerable to phishing techniques and to online scamming, for example. In terms of prevention, some of that prevention work is with colleagues like Trading Standards. I was going to mention the fire service because we do a whole range of interventions around that, but we are reliant on them making every contact count, which is why Safeguarding Week 2 weeks ago, wasn't it, Scott? It is so important because there we had a real focus on a whole council approach to safeguarding. It's not just about colleagues that I'm responsible for. It's about the waste services, people out and about, being able to support somebody, give them information, talk to someone if they're concerned. So we make the prevention quite a priority, but it's very difficult to judge whether that's been successful. But we know certain initiatives like the Trading Standards initiative, working with the fire service, are particularly successful. And there was another one I was going to. You asked me another question. Is there anything I haven't answered yet, John? I've forgotten the third question. Oh, technology. Yes. So it wouldn't necessarily be appropriate to use technology to survey somebody on grounds of protecting them because it's a breach of your privacy and dignity. So where we would be using surveillance technology, it would be as part of somebody's support package. So, for example, if I had a learning disability and particularly I found it very difficult having lots of people being around me for supervision, it may be appropriate rather than having a carer with me, I may choose, or somebody, if I don't have capacity, may choose for me. That's the least restrictive option to have that surveillance for safeguarding. But I think it would be very difficult to say that would be an appropriate deprivation of liberty for somebody to have surveillance for your own safety. But you may choose that when if you're in that position.
Yes. I was thinking more of like your Ring doorbell, so that isn't an intrusion of your privacy, but everybody who's rung the doorbell and come into the house. And as I say, I was just curious. It's interesting you mentioned about the scamming as being a way that people are vulnerable and being taken advantage of. But it was just interested that if the unknown people who committed it were known, are they strangers to walking off the street? Are they the handyman? Are they the plumber? Are they the electrician? Is there a particular group that's out there that actually calls some people and makes them more vulnerable? It's just a curiosity, but statistics would actually probably show that over the last year, who are the most likely people to be the unknowns, and that's quite interesting. Thank you very much.
Yeah, thank you, Chairman. And just to pick up on the specific point around making every contact count, I think that's a really important piece of it. And obviously we've heard this morning from very much a system process between partners, whether that's health, fire, etc., etc. For me, I think there's also a space there for our residents more broadly, for those people that are not in contact with our services. So in terms of the numbers that are being reported to the MASH, as an example, how many of those have actually come from people that ourselves that have reacted to a specific campaign. So that might be us as an organisation doing a domestic abuse campaign, also having for us as members as well. So I think we have a clear role to play in this. So I'll give you one specific example. So in the local elections for May 2021, I was out delivering leaflets, went to a house, put it through, went up the street, came back, and that particular leaflet came flying out the door. So I initially went, as someone that doesn't want to vote Conservative then, picked it up that it must be accused of littering, opened that leaflet, and there was a note on it to say, help me. So obviously it was incumbent for me to then report that. So I think there's a space there to how do we continue that furtherance of building resilience into our communities to say actually some of these issues are fundamentally wrong, and they've got to be called out.
The final page of the report actually gives that process of how people can report online anything, so that can't be anyone, as the council mentioned.
Spotting everything early, isn't it? Getting that information forward, yes. Councillor Cole.
Thank you, Chairman. I don't know if anybody else has noticed, because I have living in Beeston, that the homelessness and rough sleepers is beginning to creep back. It virtually ended during the COVID period because everybody had to go into a hotel. Yeah, they came and went, what have you, but by and large there were very, very few rough sleepers during that period. And it's starting to creep back, and it's a very, very complicated situation, isn't it? And it's not helped, I don't think, because councils are under increasing pressure everywhere, not just Nottingham City, everywhere. But also the increase in the number of Section 21 notices that are basically evicting people from their properties. And I have to say, I've dealt with a few of these, and there seems to be a huge skew against single young men in homeless legislation. They don't have the same amount of rights as other groups that are in that situation. And I don't know whether you're aware of this, but we've had this cold snap last week, and this is something I've never heard of in Beeston. A man who had been sleeping in his car for weeks was found dead in the car on Friday morning, sleeping in his car when it was -5, -6 outside. How in this day and age does that happen? And I know that we have to go by the rules and the statutory guidance that we're given, but what advice could we be giving to the government, in effect, to actually look again at the homeless legislation that is leading to young men either having to uproot because they've not lived in that area for 5 years and have to go back where they originally came from, even though they've got a job in the area where they lived. And you know, what can we do as an organisation to actually try and influence the government to look again at homeless legislation? I know that's a very difficult discourse.
Thank you, Councillor Cole. Melly wants to say that one. Okay.
I think that would be quite out of scope of the topic, but what I do want to draw your attention to is that if a single person, regardless of their sex or gender, has a care and support need, then there are just particular duties to act under the safeguarding. So if that person had physical health needs, other needs, so I think one of the things that we can all do is not assume that somebody who is homeless and rough sleeping is choosing to be there and has all the support they can need. So like I say, it's completely, we're not talking about homelessness legislation here, but there is still a duty in terms of my responsibility to ensure somebody's safe. So that would be one of the things to consider, is about their broader network. And we do have services that we commission via the Public Health Grant with Framework, where they're specifically to engage, and they have social workers that we particularly fund as well, to engage with people who are rough sleeping with care and support needs and without care and support needs, actually.
Come back, Councillor Cole. Quickly.
This is a scrutiny committee, so I'm allowed to say what I think. Framework. I've engaged with Framework 2 or 3 times, and I'm afraid they're woefully inadequate on some occasions. They were woefully inadequate earlier last week when I had somebody else that was sleeping in their car, and don't assume that we're getting a good service from Framework, because in my opinion, on some occasions we're not.
Okay, thank you. Opinion, Scott.
Just quickly on that point, and I'm very sorry to hear that the issues that Councillor Carr describes. Perhaps on those 2 points, it might be worthwhile us having an offline conversation to pursue that further.
Thank you very much, Councillor Henshaw.
Thanks, Chair, for bringing me in. Yeah, thanks for the report, Scott. This makes interesting reading. And when you look at the trends, thankfully the trends are diminishing slightly in relation to concerns received. But I still find it worrying that when you look at the types of abuse, and as touched on by Councillor Doddy, where one of the largest indicators is the neglect and acts of omission. And I'm just wondering how your group can increase the publicity in relation to getting information on how someone can report an instance of abuse when they're actually working in a private residential home. Because as members know, we've had an instance in Mansfield where we've had 3 homes shut down, which we've been briefed on. But again, I wonder if the events leading up to those closures were notified to you through the processes that you undertake. So it's good that the incidents are going down, but there are still I think there's too much abuse going on, and we've got to sort of make sure that people are aware of how they can report instances of abuse. Thanks, Chair.
Thank you, Councillor Henshaw. I think the home things, there were a lot of issues there, and the CQC was very involved in that as well. So, yeah, just that.
Yeah, I'll pick up the point generally, and then if there's anything specific about homes, and I'm sure Melanie can come in. But yeah, that is definitely one of the drivers of our communication strategies to try. That's what we're really focused on this year, is to really push out messages around how both people in communities, family members, carers can report abuse. But also, one of the things that we do, and all organisations should have, is their own whistleblowing policy as well. And that's one of the key areas that we worked on around those close cultures and making sure we've got robust whistleblowing policies in place. But it's not just about the whistleblowing, it's what then happens when that report is received by an organisation. So, yeah, that's something that will be part of our communication strategy, and it always is. You know, we put an annual report about how to report abuse, but I have a view. It's my view, but it's a professional view, that whistleblowing is often the way to find out about what's going on inside a location, whether that be a care home, a nursing home, or a close culture we've covered. So it is an important part of that process.
Thank you for that. Councillor Pringle.
Thank you, Chair. Thank you, Scott. Clarification for me a little bit, really. The report, yeah, cool, I can work with this. But I'm just wondering, and you mentioned it in the report, the Edenfield Hospital and the Panorama, so I'm going to revert back to the issues in Mansfield that we have, but I'm going to read the last part of your presentation on the last paragraph after you list the organisations which are included. On page 5 it is. And the organisations you include are exactly the organisations I would expect to engage with you to be the strength behind what the board can deliver. And the last comment is the board's main responsibility is to work together to help adults who may have been abused or neglected, and to help prevent instances of abuse or neglect. So from a scrutiny point of view, were you aware of the Mansfield issues? We're obviously aware of the CQC inability to be able to monitor and engage these care homes. And we also had officers who spent nearly 12 hours on site without any sort of ability to enter to protect the people that we're talking about here. So from the board's point of view, and the list of organisations which are included, does that lend us any more power that we can pull on to make sure we can have a speedy response to anything that raises its head again? Because these 3 were shocking, absolutely shocking. These were, or does it put you as board members? And I really appreciate the movement of the board and trust implicitly these people here that's listed.
does that put you under pressure as people who are then liable for any of the mistakes? And would you then be part and parcel of another panorama case, which we hope never happens? I just want some clarity on that as to what power we've got and responsibility.
So, in answer to your question, was I aware? Yes, I was aware, and Melanie and I discussed it, which we regularly do. Any sort of tricky issues or any particularly troubling issues like that was, then yeah, Melanie will update me since the board chair, and we'll have conversations. What if anything the board need to do next around seeking the reassurance that that's not going to happen again. As I said before, that whistleblowing is a big part of understanding the issues that are ongoing within those homes and how we are triangulating the information that's coming from a individual. But we do need to always be seeking assurance around the fact that we don't want another panorama in Nottinghamshire, hence why we did that task and training group around the closed cultures, because in the main they will be individuals or people in establishments that don't have a voice. Because they're unable to because of their disabilities. So yes, in answer to your question, I'm aware of those 3 instances. I'll probably pass on to Melanie more because a lot of them are like individual organisational responses. In terms of the legislation, if there is a situation where we have to close a home or then there is some legislation there, but sometimes it's about what the threshold is, about when that is implemented, especially in a dynamic situation, which I'm aware of what one of them was, but I'll pass on to Melanie.
So in terms of our ability to work where there's a safeguarding concern and a home closure will happen for lots of different reasons. So particularly where either the CQC, which is one of the closures that decided to close the home, so we responded, or where the home itself is given notice, which was the other closure that you refer to. So in both examples, we would, whether it's a safeguarding concern or whether there's a home closure, we have teams who work together. So within the MASH, we've got the ability to work with health and police in terms of responding to a safety concern. With the home closures, the main mechanism is through the quality market management team. So where we have a joint team with health that we monitor the quality, because supporting a home to close safely and make sure people, safeguarding involves working with the person, their relatives, it involves working with medicines management, pharmacy, general practice. There's a whole system of partners that do that in the moment. And then what we do additionally through the is a quality assurance practice network, isn't it, Scott, which is a subgroup of the board, is that where we feel we've got some multi-agency learning to do, and there's always learnings, even when we've done something well, and those closures from a multi-agency viewpoint I think went well, we've still got learning about what can we do to improve. So where there is some of that learning to do, we do that through the board where there's a safeguarding concern involved. But like I said, those closures were about their emergency because of the notice that was given, so the CQC did an immediate closure notice.
Very quickly, Councillor.
Well, I appreciate what you're saying, Chair. I wasn't being negative. I want to know what powers you have, because if the CQC are not delivering on the doorstep, they have no power to go into, which is why we had officers outside for 11 hours in a home where there was abuse. Now, for us to protect those people within that home, if there's a closure for whatever reason, and I get the partnership working to make sure everyone that comes out of home works fine, that's natural. That's what I would expect, to be quite honest, from you as a professional. But from the board's point of view, where are you in relation to the powers? Because I'm listing here. First on your list, organisation, Nottinghamshire Police, Nottinghamshire County Council, Integrity Care Board, ICB. All of these are power groups, yeah? And yet we have somebody knocking on the door while somebody says, you're not coming in, whilst we know there's issues internally. How do we gain access to protect those people on the inside? Not me on the outside, those people on the inside. That's my question. Do you have powers? Does the board have powers? Are we in a position that we change powers? So then does the board then become liable? You're saying no, man. So is the board liable then because we can't go in? but that there has to be a balance somewhere along the line.
The power to respond to any safeguarding concerns sits with the powers of that authority. So the police have got powers to entry if they're suspecting that someone's and police colleagues in the room, including Scott in his previous role, might be able to describe that. I have the ability to ensure that somebody's safe. The Care Quality Commission has the powers of entry to a home where there's some concerns. So there's no authority in the board to act. There's no power within the Safeguarding Adults Board. The statutory duty, as Scott's outlined in the report, is about the partnership, ensuring the partnership board is in place. There's an independent chair, that I have a relationship with the board, and that we scrutinise those multi-agency arrangements. But there's no power within the board itself. It rests within those individual organisations.
If I can, I'd like to speak to you after this meeting or a meeting with Melanie to get some deep answers on that. Thank you.
It's a very difficult one to really get behind. Okay. I do appreciate that, and I think the CQC was very involved in that, and it was a very quick decision. Yeah. Okay. Councillor Martin.
Thank you, Chair. So my question's on a completely different subject. We all hear about the increasing volume of asylum seekers who are a particular vulnerable subgroup. How has the board adapted to cope with the volume, the expansion in volume, because they are particularly vulnerable, especially with language barriers?
So the piece of work we did this year was about ensure because we checked this when we were doing the work, there isn't a lot of referrals come in under Section 42 for asylum seekers or refugees into the MASH. So our piece of work in general was to make sure that Circle have got the right systems in place, the right training and policies in place, that if there is a concern that it can come into the MASH and there's a multi-agency response to if there is care and support needs. But quite often that legislation for the Care Act might not necessarily cover all of the issues that could be going on in someone else's life. But one of the things that we did do, our sort of assurance, was that when an asylum seeker or refugee arrives, that they get their health assessment and their registration with the local GP, which was something that was quite reassuring, and that was quite a consistent picture. From attending one of the hotels locally, I was able to speak to staff and understand. So, what training do you get? What in particular information do you share, and what their structure is around sharing information into a centralised safeguarding team, which Circle have got. So they have to get any concerns that they've got coming in from members of staff on the ground, then they'll review them and then make an assessment as to whether this is something that is under Section 42 of the Care Act, which is the business of our board, or if it's another, they can implement other measures to support an individual. So in general, that was a piece of reassurance work we did. When House Circle come and they do a performance assurance tool return every year, which is a form of self-assessment on their own safeguarding policies and practice, and they also will present to the board once per annum around what the current picture is around that.
Does that policy expand into the city region as well then? Because obviously the city has a higher density of asylum seekers, and we're led to believe that it's having a detrimental impact on A&E at Queen's because of their because they don't get a GP, so they wait till they're ill and then they go straight there. You know what I mean? So what you're saying is that they all get assigned a GP across the county.
Yeah, so I don't know about the city. I didn't do any assurance work around what happens in the city, so I can't say for sure. I can't stand here today or sit here today and say that happens in the city as well, because I don't know. And then as for any, I don't know about that. But I just, we as a board know that Circle, the way they're organised, is in a regional basis. So it's not just for the county; it's a regional response that they have. So that safeguarding team I referred to, they will get referrals in from not just Nottinghamshire, but they will get referrals from the city, probably from other local authority areas as well, into their team. So one of the things that they try to do to us. And one of the things we've got them doing now is breaking down some of their data so that we can actually see it from a local authority boundary area. And they're still in the process of doing that.
Thank you. I don't think there are any further questions. Oh, sorry, Callum. Sorry.
Thank you, Chairman. Yes, I'll wait till the end. So I'm quite new to this committee, so you may have already covered this in a previous meeting, but the one thing I wanted to highlight for myself was the amount of abuse apparently in care homes. So you've got 573 just added up between nursing and residential. I suppose my question is, in the types of abuse, do you have the information where you've got that attributed to, for example, a location? So is there one type of abuse that occurs in more than one location, essentially? So what abuse is happening in these care homes? And I suppose the follow-up to that one is, what work is actually being done to work with these care homes? Now, you may have already addressed this previously, but I'm just reading, for example, in the prevention and engagement sections of your report, and I can't really pick up on any specifics to care homes. And I suppose an additional question is, in terms of the care home staff, is that being inflated by a certain few care homes or locations, or is it the fact that in care homes there's just a standard accepted rate of abuse that's happening in there? I suppose those are my questions. Thank you very much.
Thank you, Councillor Bailey.
So, in terms of ultimately the last question is the one we'd always try to prevent any abuse where we can in care homes, but unfortunately it happens and probably will continue to happen, unfortunately. But the fact that those reports are coming in is, you wouldn't want it to happen. Of course you don't. We would want to live in a society where nobody causes anyone else any abuse, neglect or harm. But the positive side of that is that the reports are coming in, which allows the multi-agency response to a particular adult to be instigated to make that person safer. But then, and I'll pass on to Melanie in a second, but some of the teams that she's got working for her who go in and do some of that quality assurance work when they're very much in the same CQC, is that it's sort of intelligence based. So when they get some information about risk or needs, then they will respond to that in a way that provides scrutiny. And I have, in the role I've done over the year, not everything's in the report, but you do see that in other locations. The ICB have a good scrutiny and audit regime as well around any locations that are commissioned, because quite often a lot of the homes you're referring to are joint. There's joint commission goes on there between health and local authority, and there's also, part funded by individuals or their families and the local authority. But I don't know if you want to come in a bit.
So yes, the numbers would be clustered. So we would expect there to see homes that had an issue. So it might be staffing levels, for example. It might be something more broader about not completing the appropriate care documentation or medicines management. So we would generally see a cluster of those issues, and we have in place contractual management. I think it's really important to note that we're responsible for about 40% of the people that live in care homes. About 40% of people fund their own care, so don't have a relationship with the local authority, and the remainder are funded generally by the NHS. So that's why the board's so important, because as well as the prevention agenda has to sort of support our own staff reviewing. So I'd only have contact with a small proportion of people that reside in care homes, but that communications bit about the GPs, I'm looking at John Doddies if he represents GPs, but GPs going in there, district nursing, there's a whole raft of professionals who would have more regular and daily contact, including people themselves and family members. So a bit about information advice to family members is really important, so family members know what to do if they're concerned about the quality of care.
Thank you very much for that. Thank you. Do you want to come back? No, that's absolutely fine. Councillor Fielding.
I would reiterate the importance of getting information out to family members that go in and out of care homes. I mean, I spent over 12 years with a mother in care, and it, as I say, it's a roller coaster ride that nobody particularly want, but you need to have the information available to family members who've got of where to go if they believe things aren't quite as they should be. And I, in a going into another care home, did report them to the QCQ, because if you've got any doubts whatsoever that people are at risk, you report it in an appropriate manner.
And I think that's something we need to encourage. Yeah. Okay. Thank you very much. If no other questions, I'll ask Martin to read out the recommendations, please.
So just as the report, because there hasn't been any request for any particular further information. So the first is the Nottinghamshire Safeguarding Adults Board report for 22-23 be noted, and that the committee continues to review the work of the board by receiving and considering its annual report each year.
Thank you, Martin. I move the recommendations. Second. All those in favour? Thank you very much indeed. Thank you. And thank you, Scott, for coming in this morning and visiting the annual report, and also all the work you do with the Nottinghamshire Safeguarding Board. Thank you very much. And I think it's out in December. We wish you compliments this evening. Thanks for coming in. Thank you. Right, we move on to agenda item 5, adult social care and public health performance, risk and financial position for quarter 2. And invite Councillor Carlton to present this report, please.
Yes, thank you. So on behalf of Councillor Barney, I have the pleasure of presenting the Adult Social Care and Public Health Performance Risk and Financial Position Quarter 2 report to committee this morning. Purpose of the report, as is laid out on page 39, and your recommendations are over on page 40. At that point, I will pause and ask the Corporate Director to speak to this. Thank you.
So within your pack, you've got some summary slides and a fuller report. So I really encourage you to look at the fuller report, because there we share some of our stories of difference and the impact that we make to people's lives, which I think is really important. And just to note, this report goes in tandem with the report you'll hear from the Director of Public Health about how we're improving public health outcomes. So the two relate to each other. So I'm going to be covering off briefly the financial performance. I'll then be talking about some of our key performance themes and drawing your attention to our key risk areas. We've just had a really good extensive coverage of safeguarding and risks in the care market, so I probably won't dwell on those too long, but I will touch on them. And then really, like I say, draw your attention to some of our stories of difference, the impact having on people's lives. So our financial performance, as it was at month 6, is there. So we are seeing an overspend on packages of care, and this is across all care types and all ages. And this is related to 2 key areas. So one is that we're seeing older adults requiring more care per person, and we think there's 2 main drivers for that. First of all is people waiting for care. I think is much more significant. So older adults we're seeing are waiting for elective procedures. There's huge waiting times for NHS healthcare. We're also seeing that people, the effects of the pandemic still, and I've talked about this before, that people aren't as well. There's a well-being burden from the pandemic, and again that relates to some of the availability of care. But we're also seeing that older adults are surviving longer with health conditions and therefore needing more care. So particularly when they've had a crisis, so a crisis either with a care package difficulty, and sort of the way Councillor Fielding's referenced, it's a roller coaster often at times, and also when somebody has a hospital admission. So that's increasing some of our care costs. For working age adults particularly, we're seeing a pressure on the cost of care per individual, because of some of the cost of providing that support has increased with the amount of support that somebody needs. We're currently expecting a small overspend by the end of the year, so that's the current forecast for the year end. Public health is a ring-fenced grant, so we have money coming in and we have money coming out. And Jonathan Gribben has referred before to some of the projects that we got in place to spend public health reserves. Public health reserves are generated where our main contractual expenditure has some underspend within it. So, and I think the reserves we've talked about before, where we're using some of that reserves policy to support areas where there's more pressure. So that will be in areas such as sexual health, domestic abuse, and we've funded additional activity. Jonathan, I don't know if there's anything you wanted to add to the report.
On that particular point, I can just say that I'm working with portfolio holder and his deputy around the use of the public health grant reserves, and that work has yet to reach completion and will be subject to their direct input. But some of the recommendations that I'll be taking to them will be that we look to how we can apply those grant reserves, not only in delivering public health outcomes, but as far as possible, supporting other areas of the council's work as well. So one of the opportunities for us, I think, that I'll be looking forward to discussing with the portfolio holder will be around increasing the capacity around drug and alcohol treatment services and around domestic abuse, which will enable the council to roll out, for example, some of the work that it piloted in Newark around family safeguarding and support. Now, all of these things have yet to be confirmed and formalised, but I think there's a real opportunity there for using the grant in that way. Thank you.
So, as you know, across the department, we've got a well-established programme of change and transformation, which is about trying to improve the lives of people closer to home. And this slide just highlights, we call it benefits realisation. That means some of the outcomes that we're trying to improve to people. So strength-based practice is designed, it says it's at risk for some of the savings. And the reason that hasn't generated a financial benefit, so people are being supported better at home, so our outcomes against individuals is improved, but the financial benefit is at risk because of the increases in the cost of care that I mentioned in the financial report. And given in the pandemic we use a much greater increase in interim care beds to support hospital discharge, which was the policy that we had nationally at the time. So that again has seen that some of that people being admitted into short-term care has translated into longer-term care. Our reablement services continue to go from strength to strength, and we had a period of time where we were diverting our reablement capacity to be supporting some of our pressures with the care homes and market pressures, but now the home care market has recovered, we're able to use that reablement capacity to be making people more independent, so that's really helpful. So we've done a whole review of our client financial services over the last 12 months, and particularly about trying to have a new appointee and deputyship team. So this is where somebody doesn't have the ability to manage their own finances, and where there isn't somebody in their life that's appropriate to do that for them. We have a deputyship scheme, and we've extended that to enable that basic right to have your assets protected and your income protected to a broader range of people. So that's been really positive. And then we've also been doing a piece of work with Our Voice, our co-production group, on the style of our letters. So we had a huge amount of complaints about the standard letters weren't easy to understand and was language that was patronising and confusing and caused actually people some upset. So we've had a really important engagement piece of work to improve that. We've trained staff. We've had, like I said, the input of people with lived experience to help redesign those letters. So there's some things I think is really important. The fact that we charge people for care, and that's a big part of the way social care operates, often doesn't get much attention at Select Committee, but it's really important that we do that well, so giving the right information. And I don't even look at Councillor Fielding when I say this, but billing people correctly and keeping informed is something that we don't always get right. So I'm really proud of the fact we're trying to improve work in this area. I think I really want to go to some of our key performance themes. So we have a set of metrics. Some of it is set for us nationally, some of it we set locally, which are really important indicators of how well adult social care is performing. So as you will be aware that the hospital discharge work with our 3 acute hospitals has been important. I mean, let's be honest, it's been important for years, but particularly important in recent times given the pressure on hospitals. And we're really proud of the work we've done on understanding our data, and that's an award-winning service actually, that piece we've led with particular support of Nottingham University hospitals to get the understanding of people when they're well enough to go home and what's getting in the way of them doing that safely. So we're really proud of that piece of work, and that started to impact on our performance, as you can see from the slide. We touched on safeguarding already, so I won't dwell on that, but I did want to touch on long-term reviews. So a review is a process that's in the Care Act, and that is a basic review of somebody's care and circumstances, and that's really important for the position that Councillor Bailey mentioned earlier about how do we know that people are safe, whether they're living in their own home or within a care home, and the review is a very important part of that. So we have constant focus on reviews. Although we have a target that we want to achieve that everybody has a review, statistically it's not possible because of people dying or passing away and a whole range of other circumstances. But nonetheless, that's our ambition. So it's really important that people have that basic right. So we continue to have relatively strong performance here, but not yet strong enough. So it's not okay, is it, just to compare ourselves to the rest of the region or nationally where we perform much higher. We really need to be striving, like I say, to have that basic right to everybody. And just to touch on carers, so again we've had a little bit of commentary about the unpaid carers. So this isn't colleagues that work in the services, this is those that support somebody. Some carers will identify as that. Some people who are parents, for example, probably wouldn't consider themselves a parent or a daughter or a family relation. But within Nottinghamshire we do have some 30,000 people that have a role in supporting somebody else as a carer. We launched our strategy several weeks ago. It's a strategy that's across health and the city, so it's a real partnership piece. It was co-produced with people, so carers themselves helped design the strategy, helped on the implementation plan. And we launched it as part of National Carers Week, and we also launched our local Carers Challenge. So if you'd like information on how you as a committee or individuals can support the Carers Challenge and make a pledge to carers, let me know and I can send you the link. This piece is really important because the more we support carers to manage, we know that the outcomes are better for that person, and we prevent some of that safeguarding issues of the knowns. We've had a lot of focus today, haven't we, about the knowns, but we also know that a carer is also a potential risk to somebody, with abuse and neglect. So that support's really important to prevent that happening. And I think the last thing I just want to draw your attention to is our annual conversation feedback. So adult social care, I think, is really fortunate in having sector-led improvement funded by the Department of Health and Social Care. So this is a regional improvement programme where we provide collective challenge to each other. So we look at each other's use of resources, so how we spend money and whether it's wise enough, whether it brings about the outcomes that we hope to achieve. We look at our quality standards and performance standards, and we have what's called an annual conversation, which is an expert in the field comes and looks at our strategies and how we're delivering against them and gives a view of what we're doing and where we need to improve. So we had some real strengths noticed about strength-based working, and the quote from the review was commensurate the commitment from the department to working in a strengths-based way. She said was just impressive. And where we needed to improve was to improve our quality audits. So to make sure that the process we have where we're looking at our social care practice, whether that's OT or a CCO or a social worker, whoever's undertaking that piece of work, we audit that regularly to make sure that we're learning from the audits. So that was a really helpful feedback there. Again, about becoming co-productive. So you've heard Councillor Barney talk about the big conversation and how proud we are of that event and the listening work. So that's been noted as a strength nationally, the practice we've got there. So now the next steps will be about how we have our co-production forum, the Making It Real forum, engaging with our political leadership. So it was noted that was the next stage of our development. I'm not going to talk you through all of that because you've had the opportunity in your pack to see where our strengths and weaknesses were through that process. And then I just wanted to really leave you with a story of difference. Like I say, I think I'm not going to present every slide because you've got them there to read and they're there as detail, but it's just to leave you with this story about the impact that re-ablement can have to increase somebody's confidence to get someone back to recover from a crisis. So if I might, Chair, leave the presentation there rather than talking through every slide, but happy to take questions.
Thank you very much, Melanie. Councillor Cole.
Thank you, Chair. First of all, I mean, I've been a county councillor since 2005, and one of my biggest inboxes for casework in those days was social services cases, usually care plans and people not turning up, things like that. I have to say, Melanie, now it's very rare that I get any casework to do with social services, which I think is an indication that things have improved absolutely dramatically. And if you pass that on TT, because I know it's an incredibly stressful job being a social worker, and I think we're lucky in Nottinghamshire that we do have such a good social services and adult care. Anyway, the biggest threat to that, of course, is finance. And I just want to clarify here: was this financial forecast done before the autumn statement? So we've got to build in the increase in minimum wage into there, have we? Can I ask how much we're expecting that to alter the figure there? And also, I was going to say something else, I can't remember now. It'll come back to me. Just that question at the moment. Thank you.
Good old age, yeah.
Yes, it was before the statement and before the local government settlement. So that's where we can revise the forecast. Usually it's Christmas Eve, and we understand what resources local government will have.
I heard an actual leader of a council say the other day, it's not really knowing how much money we're not going to get. It's not knowing when we're going to find out how much we're not going to get. That's the problem.
It's always late in the year. Councillor Fielding.
Thank you. Paragraph 20. I'm really pleased that we've re-looked at what we're sending out to people and how we're doing it. In dealing with finances on somebody else's behalf is a challenge, and that families take up. But when you receive literature from the county council that can be somewhat upsetting, me getting it was somebody who could deal with it. But when it's a vulnerable person that could have been receiving it, that did concern me. So that it's been dealt with. I'm pleased. Thank you.
Thank you, Adam. There's a question there. Councillor Pringle.
Thank you, Chair. Two quick questions, really. I'm going to give Councillor Carlton my second question first. Just let me know what 61% of 217 is, please, on paragraph 59. And there's a reason behind that, Scott. We've mentioned the cost of care increases, and again, that's prior to the statements that have come out. We've understood that there's a small overspend, and we also have heard that we're using reserves to prop up the provision. So we're putting a sticking plaster on there. So are we? Shall we forget that? We are. You don't have to tell him the answer, miss. You did. So are we expecting, or do we know, are we clear on the amount that we need to provide to sustain, because this is a positive report, to sustain the care that we're providing? And I was being facetious with my first question to Councillor Carlton, because it's a bugbear of mine whereby we use numbers to highlight something and then percentages to back it up. And in actual fact, the public health report later on has done exactly what I asked it to do. It's given me numbers and a percentage, so I completely understand that. I just wish that's what we had in all our reports, Martin. We had numbers and percentages rather than trying to bamboozle people, just to make it clear. So my question really is a financial one. Are we using the reserves, knowing the cost of living crisis, knowing the autumn statement increases? What figure are we looking at to maintain this positive report going forward? Thank you, Chair.
Thank you for your question, Councillor Pringle. Just in more broader terms around the reporting, I probably would agree with you in the use of percentage figures. As I understand it, there's no planned reserves within the budget.
And I think we've taken that on board as well. Yeah. If there's no other questions.
On page 45, there's the latest forecast variance of 5.5 million as compared to the previous one of 4.68. And this is where I'm going to talk percentages. Councillor Pringle is actually a 20% increase, and that in itself is a worrying trend. I'm acutely aware that you'll be acutely aware of the danger there, and really what we're going to do to actually stem that if we don't get the money from central government.
So in period 7, that has reduced now to 1.5 million overspend. So in this report, we hadn't put use of our discharge grant and market sustainability grant as an income line, because we were making sure we met the grant conditions with the stakeholder plans that we had signed off. So the market sustainability grant is agreed with the care market, and the discharge grant is agreed with the ICB. So there was a process of agreeing where it was going. So then we had to sign it off with the finance team against the grant conditions. So it's a very long way of explaining. We didn't pay income until period 7.
Thank you very much. And then Councillor Carr.
Yeah, just to quickly. That's probably the best feedback I've had this morning. Just add to that, what the corporate director has just described, and it's a question that I recently asked in one of Councillor Barney's briefings. Is the sort of vision down the line in terms of usage when we know grants are coming in and how we're recording them. My personal view is it just gives a little bit of a false perspective at times between the various periods of reporting. Absolutely take the point from the committee this morning around the projected overspends, etc., and the importance attached to that. And obviously I will remind committee that behind every financial point, percentage, figure, however we report it, these are real people.
Yes, thank you for that, Councillor Scott. Yes. There's no other questions. I'll probably ask Martin to read out the recommendations. But I say this, as it's been said, it's quite a positive report. There's a lot going on, but it's, we're in a service which are always under a lot of financial pressure. We're an aging society with more complex needs, and so it's always going to be pressures on the budgets on this. But anyway, Martin, you read the recommendations, please.
So firstly, that the report be noted. Secondly, that a further report on performance comes to the March meeting of the committee, and that finally we will do this encompassing so that all reports to the Adult Social Care and Public Health Committee display statistics in whole numbers rather than as percentages.
Move those recommendations. Second. All those in favour of recommendations? That's unanimous. Thank you very much. And we'll move on now to agenda item 6, improving the health outcomes of people in Nottinghamshire. And again, invite Councillor Carton to present this report, please.
Thank you, Chairman. On behalf of Councillor Barney, again, I have pleasure introducing this report. At that point, I'll hand over to the Director of Public Health.
Good morning, Chair and Councillors. Thank you. I'm happy to take you through this report. Chair, I need to check at this point. I have a very short presentation which I omitted to send to Democratic Services. With your permission, I'll use it now and circulate it, but with my apology that members didn't get it in advance.
That's fine, thank you.
Thank you. What I'd like to do then is to share a report which I think will help you towards the purpose of the report. You'll see here that one of the purposes is to support you in prioritising areas for some future attention during the coming year. And on the one hand, what this report does that you've got in front of you already is to set out some information from what we refer to as the Public Health Outcomes Framework, which is nationally shared information. And you'll see there in the appendix that is a vast array of information. So in helping to support you towards what you might wish to choose to scrutinise, what I will do first of all is to share a presentation which I think in the first instance draws our attention, if you like, to the big picture before you look at the detail. And okay, so let's take a look at the big picture then for a moment or two, because of course we have a statutory duty as a council to take steps to improve the health of the population. You'll find that that is reflected very clearly in the council plan around the ambitions set there, in the joint health and wellbeing strategy that Councillor Doddy oversees. If you were to look at what the government sets out, it's very clearly articulated there that the strategic direction that the Secretary of State takes is to improve and protect the nation's health and to improve the health of the poorest fastest. And one of the duties that the County Council has as part of its health improvement duty is to have regard to the guidance that is published by the Secretary of State. And so we need to focus in particular on the public health outcomes framework as we think about improving and protecting the health of people in Nottinghamshire in particular. And government sets out for us that the focus that we're to take is not only looking on extending the length of life, life expectancy, but it's also to be on how well we live in Nottinghamshire. So in other words, in what we call healthy life expectancy. And again, underlines to us the duty that we have, which is that must also be on reducing the differences between people and communities from different backgrounds in terms of their health outcomes. The public health outcomes framework, which you'll find set out in detail in the appendices, picks that theme of both the years of life lived, but also how well we live. And you would find within the public health outcomes framework 4 domains, some things that look at the wider influences that I'll come back to, some things that focus very much on what we can do to improve health and also protect health. And it also has a domain that looks at early deaths. And it's really action across all of those domains that is required to improve outcomes and reduce inequalities. I'm going to focus just for a moment or two on looking at avoidable deaths in Nottinghamshire, and just to use that as a bit of an example for you. So avoidable deaths are deaths that can be prevented or avoided by treatment. There's an internationally agreed definition around that. And in Nottinghamshire, in the period 2015 to 2019, which is the period for which we have, it's the most recent period for which we have up-to-date information that can be compared across the whole country, you'll see there that there are 8,620 avoidable deaths. So that's a rate of, for every 10,000 people, 23 deaths per 10,000 people per year. And it won't surprise you to know that the distribution of that across the county varies enormously. And down in an area of Rushcliffe, to take an example, it is as low as 9 avoidable deaths per 10,000 people. And as it happens up in Worksop, to take one example, it's as high as 55. So you can see that the disparities that are well rehearsed here also appear in this data around avoidable deaths. But if we're to think about what action can be taken around avoidable deaths, we need to take a look at what the causes of those deaths are. And again, I don't think it will surprise you to hear it's around cancer, circulatory disease, chest disease in particular, but also things that are alcohol and drug related and other causes as well. And there is work that we can do around prevention, and there is work that we can do around around treatment as well. And as you will go on to see, both of those are important, but there are different parts of the system applying themselves to action on those fronts. Just for a moment or two, allow me to show you just how much disability and disease in Nottinghamshire specifically is changeable, is avoidable, and the disease groups that appears in and the risk factors for it. So we know from work undertaken internationally in something called the Global Burden of Disease, and work which my colleague Dave Gilding is at the back there helps us to interpret that in Nottinghamshire County, if we take a snapshot of Nottinghamshire County, their residents have over 51,000 years lived with disability that could be prevented. And if you were to say, well, what kind of diseases and disabilities are we talking about here? Well, they're listed in rather small writing down the right-hand side, and they're the things that I referred to earlier on. We can talk about cancers, circulatory disease, chest disease, and so on. But if we think about the risk factors, the causes of the disability and disease, and bearing in mind that all of this 51,000 years is avoidable potentially, well, we see it falls across these risk factors. And you can see at the top there that overweight and obesity in Nottinghamshire accounts for the greatest number of years of disability and disease. And you can work your way down those different risk factors, picking up some of them as we go. The next one down is high blood sugar. I'll come on to that in a moment. Some of the things associated with diabetes in particular. Next one down, tobacco, an enormous cause of avoidable disability and disease. I'm going to skip forward because, in fact, I'm going to move past this one. It's a little bit small. I've missed a slide. A slide is missing. Never mind. Let me pick up then that. Yes, I've missed the slide. Never mind. I'm going to skip forward to this to come back then to pick up that example of high blood sugar associated with diabetes in particular. The green box at the top there captures in just diagrammatic form where we might intervene around some physiological risks, typically the kinds of things that health and care services are able to intervene on in order to address some of those risks around our health and well-being. So high blood sugar, high blood pressure, high cholesterol are all things which our health care services are well placed to address. Some of those other things, though, that I read out from the list are much more to do with what we might badge up as behavioural risks. So that's use of tobacco, poor diet, physical activity, and so on. In many cases, those behavioural risks have a direct relation and impact on our health and well-being. In many cases, they actually also influence some of those physiological risks themselves. But if we want to understand the causes of those causes, we can take a step further back again. And it's worth keeping these things in mind as we think about the public health outcomes framework and the full spectrum and range of things that we need to work on. Because the causes of the causes sitting behind those include things like social isolation and lack of social support. It includes things like that one's own perceptions of what kind of power and agency one has oneself to take action and make changes in one's own life. Also loss of meaning and loss of purpose of life. Those are the causes of the causes which sit behind some of these other risk factors. And then in the pink box, sitting around some of these things again, some of them having a relatively direct effect on health and well-being, others of them having an indirect impact through these other boxes I've set out for you. We've got things like poverty, low social status, poor educational attainment, and so on. So I'm really wanting to underline this to you to help you in a moment or two, support you in determining what you might wish to give some further scrutiny to during the course of this year, or indeed this morning. In doing that, let me draw your attention to this diagrammatic from the King's Fund, which underlines very nicely that if we're setting about taking steps to improve the health of the population, as is our statutory duty, we need to think in terms of the wider determinants of what are called here the wider determinants of health, the building blocks for the health of the population. We need bottom left-hand segment here to be working very closely with our partners in the NHS, because absolutely healthcare plays a really important role in this as well. We need to be working with those who are able to influence the health and well-being in terms of places and making places that are healthy for us, as well as top right-hand corner, focusing as well on some of those lifestyle risk factors for health and well-being as well. So those are what some people refer to as the 4 pillars. But I'll come back to this point before coming back to you, Chair, just to underline then the importance then of focusing on some of these building blocks alongside some of these other factors. It's very tempting when we invest quite a lot of the public health grants around commissioning particular services to focus on those, but exclusively on those, important as they are. And I'm just wishing here to give attention to some of the other things that are of absolute importance as well. And earlier on, Councillor Carr, you touched on an issue that related to housing, I think, and for sure something that demands further scrutiny at some point. So, councillors, I've shared with you in the report that you have received the full public health outcomes framework at the back in the appendices. We've tried to draw your attention there to those outcomes where we're doing very well or similarly compared to England average, but we've also tried to focus in on where we're doing less favourably than other parts of the country. And in paragraph 24, I've also taken the liberty of suggesting a couple of areas that you might wish to focus on over the coming year and worthy of further attention. Thank you.
Thank you very much for that presentation, Jonathan. Yes, some interesting slides there for us to look at. I mean, I was listening to a programme coming in this morning on the radio where they were saying obesity will overtake cancer as a causes of death within the next 10 years, you know, which is something, you know, prevention is always the better the cure, and, you know, lifestyle choices, but it's getting that message out there, and it starts at a younger age as well. It sort of goes back to what we are doing with healthy families as well, to I suppose educate is probably not a good word to use, but to encourage people to take better lifestyle choices as they're growing up from a younger age into later life. I'll open it up for questions. Councillor Reg, you're there.
Yeah, I liked all the facts and all the stuff in the presentation. What is preventing us, or what's preventing you from getting on with it and delivering on it?
Thank you for your question. So we've been getting on with it, and I'm pleased to say that you can see across a range of the public health outcomes that although there are some that fall to the responsibility of other parts of the system, there are many that fall to us as well. And in the latter part of the report that Melanie brought to us, we were looking at some vital signs. There's brilliant work that we're doing, for example, around the Healthy Families Programme, where we achieve very high level of performance. That's just to take one example around early years. There's other really good work going on at the moment that Councillor Carlson has a role in overseeing for us around drug and alcohol treatment and recovery, starting from a very challenging situation, but putting in place some really good arrangements for people in Nottinghamshire. So addressing some of the unmet need around drug and alcohol treatment. If you're asking me what prevents us, well, one of the things that prevents us right now is that we don't have visibility over the resources that will be available to the council beyond next year. So the Section 151 officer helps us with that by providing us a planning assumption, but it is very difficult to plan long-term, sustainable, high-impact public health interventions when you only know what the grant is going to be for a year or perhaps 2 years ahead. If I would add to that, our partners, of course, across the integrated care system, who also have a role in this, are also similarly very challenged at the moment. Thank you.
Councillor Doddy.
Yes, indeed. I think, Johnson, you could spend a whole day discussing this topic and still not satisfy everybody's sort of interest in how we can improve the health and well-being of the population and increase people's life expectancy in Nottinghamshire. It's one of those areas where in item 11 where it says public health has made savings on sexual health and health checks. It's one of those areas where they're not as much savings as they are underspends, where we spend less money, but that doesn't improve the actual outcomes, as Councillor Adair was mentioning. How do we not get on with it? It's quite often because of health checks have stayed stubbornly around 50% of those invited in from as long as I've been here, year after year after year, and therefore there is a lack of ability to engage people in that. And similarly with sexual health services, less is not often more in terms of spend. More is more in that if less people are diagnosed with chlamydia, it doesn't mean less people have it. It can mean that you've actually tested less people. So I think there are interesting ways of looking at that. You're quite right when you talk about obesity as being the big killer going forward, and indeed the health of the nation. Instead of getting longer and people expected to live for longer periods of time for the first time in 100 years, it's apparently stayed the same and is indeed falling off. And most people, although some put it down to cost of living and the squeeze, the large thought is that it's obesity that's actually going to stop us living on average to 100 over the next number of years. It's going to plateau that and cut it down. It is interesting that I think that the big win in obesity, and Jonathan might be likely to back me up here, Reg, is not actually going to be how much money public health actually spend on obesity. It's not going to be on how we deal with people's diets and foods. It's going to be won by the pharmaceutical companies. It's going to be won by Novo Nordisk putting out Wegovy. It's that injection that you can have once a month that lowers your weight. Obesity and the tackling of obesity is not going to be won by diet and exercise and health departments. It's going to be won by pharmaceutical departments, and the money to be made sheer greater than anything COVID could have ever done for pharmaceuticals in terms of the cost of vaccines. The injections, once they become available, is what's going to actually turn that curve around, purely because it's driven by money that pharmaceutical companies will be able to make billions of pounds out of. So I think we'll work on that, Jonathan, over the years to come, but I think our success will be on the back of the pharmaceutical companies. I really wanted to talk about, as you mentioned, smoking, and the fact that if you walk from Rushcliffe to Mansfield, the people in Mansfield live 7 years longer. And what we've been at pains to point out to people over a long period of time is that if you wanted to have that in the morning and you wanted to make the people of Mansfield live 3 years less than the people of Rushcliffe, you could do it overnight by stopping people smoking. 50% of the entire differentiation in life expectancy across the whole of Nottinghamshire is down to one single factor. But you did put up diagrams there to show how one single factor can influence people, because it's the leading cause of death, premature death, but it's not the leading cause of living with illnesses and diseases, which you put forward as diabetes and blood sugars, etc. So that differentiated in that area. The bit I was looking at here was 81, which is illegal tobacco, and I did a little talk recently for somebody on illegal tobacco. And Nottinghamshire in the last 6 months seized 142,000 cigarettes which were illegal, costing over £70,000 in savings, and vapes of 6,800 were confiscated. And illegal cigarettes, as the cost of living crisis, etc., pushed in on people. People can't spend 14, 50 quid on 20 cigarettes. They actually are looking for ways of cutting the cost. Illegal tobacco and cigarettes brings crime into the poorest areas of Nottinghamshire. It allows children who wouldn't be otherwise able to afford it to buy cigarettes for half the price, £7 or £8 for 20. It increases dependency. It takes away any tax benefits for the government, and it completely obstructs the public health's opportunities to intervene in smoking, because by its very nature it's a subversive activity. And secondly, the big expendable, or the bigger growth, is in the vapes. We all know that vapes are a real challenge for children. We all know that illegal vapes with hundreds of puffs in a vape are now being sold on the illicit market in a greater quantity probably than illicit cigarettes. And that's where the trading standards, etc., will find their works going forward, is the children with the vapes. And the most important thing is that they fall outside our ability to directly intervene in these markets, because by their very nature, they occur in a subversive way. So I think we've got a lot of areas where we can, as Councillor Adair says, what is it that stops us getting forward? Quite often it's a myriad of things that stop us getting forward. And in many ways we've made some fantastic moves forward over the last number of years while you've been here, Director Gribben. Not least the fact that we're about to head down to Parliament to ask the Secretary of State to introduce water fluoridation for the entirety of Nottinghamshire, which will improve 30% of the dental decay of the entire population of the children of Nottingham, and will be primary one of the greatest achievements over time if we can actually achieve that. So yes, I welcome the paper, but see, the simplest of questions, Reg, sometimes are the best questions. What is it that stops us going forward? And that's just a few of the areas that are stopping us. Thank you.
Thank you, Councillor Dudley. I don't think there's really a question there, but no, thank you for all your comments there. No, they're very viable. And the thing about vapes, I think the thing about vapes is very poignant, because vapes were introduced to help reduce the health risk, but because they weren't regulated anyway, they become a health risk in their own right, and it is something that, you know, we needs addressing seriously. Councillor Dare, sorry.
Just on vapes. I'm talking about vapes now. They test the things. They test seeing children stand on the street corners vaping, and all these new vape shops now that are opening up, and God knows what's going on in there. We don't know. But I also notice now we've got no smoking in restaurants and pubs, but we have got vaping. Is there any legislation that prevents, like, open spaces where no smoking is, like restaurants, pubs and places like that, that says prevents vaping as well? Because you now go into a pub, you're not choked with tobacco smoke, but you're choked with vape, whatever it is.
Do you have an answer to that?
Well, I don't believe there is, but it would fall to, I think, districts and boroughs to enforce it. It's not something that would fall to the county council in any case.
Sorry, I don't get that. If we're here talking about public health, it's a public health problem. Why can't we, as a county council, go to the districts and boroughs and say, this is a problem, can you help us to do something about it?
If you decide that that's something that you want to focus me on, I'd be very happy to do that. And yes, of course, I can work with districts and boroughs to influence them in exactly that way. In terms of the scrutiny of the current public health functions, it's not something that we're currently working on.
Councillor Henshaw.
Thanks, Jonathan, for your report. I found it very interesting that we seem to be getting back to the same old themes of we actually know the problems in relation to why people aren't living longer, healthy lives. We know that smoking is bad for everybody. We know that people need to take more exercise and reduce their intake of alcohol. And yet again, we have a situation where we find ourselves that after many years of the life expectancy of people increasing, we're in a situation now, for whatever reason, that life expectancy is diminishing, and healthy life expectancy is diminishing. Hopefully the trend after the pandemic will start to rise, but you know, it's quite clear from your report, we know why there are problems, and the problems mean that the most disadvantaged areas, and it's highlighted in your report, live an average of 8 years shorter than people in the most advantaged areas. So we know that is the case. So therefore, I think we need to redouble our efforts and concentrate on those areas of deprivation so that we can sort of mitigate that trend. And I think that is a thing that we, as a county council and as a government, any government must concentrate on. They know why people are dying younger in certain areas, and you can have all the levelling up you want in the world. If that money isn't going through to those deprived communities, then this trend will continue. Thank you.
Thank you. I don't think there's really a question there, but thank you again, Paul, Councillor, for your comments. Councillor Pringle.
Simple question. Why do you allow people to smoke in hospitals outside the main entrances?
Yeah.
Councillor, if it was within my power, they would not be. But the hospitals are run by the local NHS providers, whom we continue to work with to influence them on that. And I think with the additional monies that will be coming with, we trust, with the smoke-free generation work at a national level, I think that will be a catalyst for us to, redouble our efforts on that. There's an opportunity there, and I look forward to the time when we have sufficiently denormalised smoking and put arrangements in place across the country and in Nottinghamshire so that we don't have 1,000 young children and young people taking up smoking each year to become, if I might say, the casualties further on down the line. So, yeah, we'll be pleased to work with our NHS colleagues on what you've highlighted. Thanks.
Thank you. Councillor Martin.
Yeah, I fully agree with what Councillor Dodley said earlier on, and everything he said was, what we've been looking at, health checks again, keep coming up, don't they? Obesity, and vaping. They're all the things that we have been looking at. But one of the things that has cropped up more recently, and I think it's due to the contract with dentists, is hygiene and dental practices not accepting NHS patients. And in this line here, percentage of 5-year-olds with visually obvious dental decay is falling below the national average. What can we do with the public health grant to sort of alleviate that, or try and drive it in a different direction, or is it simply down to the contract that dentists have with the government, and that's the issue? Because in the health scrutiny, for the first time ever, we got dentist people in here for Nottinghamshire, and that was the crux of the problem, the actual contract with them. Is it due for renewal, or because that's going to have a serious detrimental impact on the health of people going forward if dentists aren't going to be accepting NHS patients.
Yeah, thank you for your question, and I think there might be a two-part answer to this one too. So I think a number of councillors will be aware that the responsibility for commissioning dental services lies with the NHS. In fact, it's one of the things moving to Nottingham and Nottinghamshire ICB. So the responsibility sits with the ICB, with the local NHS. It's not a council responsibility. The public health grant, it's required that the grant is invested in public health outcomes, not in dental treatment services. But let me say, and kind of coming back to what Councillor Doddy touched on, the scarce resources of the local NHS would go further if we had fluoridation in place. Because as well as alleviating a burden on some individuals, it would actually relieve the system of some entirely avoidable costs. That would mean that the few dentists that we do have, scarce as they are, would actually be able to go a bit further, if you like, and to focus on other needs.
Thank you. Councillor Coe.
Just on that subject, of course, one of the biggest problems is the NHS dentist contract that was brought in the early 2000s, which has caused a huge problem, but that's just straying off the subject. But I've looked through here, and whilst we have got some vaccinations which are in the better than England, the trend is downwards with regards to vaccinations being taken up. And I have to say, a lot of it is to do with the misinformation that is put about by some people. I mean, I publicised the flu and the COVID boosters on my website, on my Facebook site, and got hurls of abuse from people saying that do I want to kill people and things like this. But people see those, and we live in a society where my parents' generation, and my parents were quite old when I was born, so they were born in the early 20s. They saw rickets and they saw measles. My cousin Ralph is deaf in one ear because he caught measles. And they don't realise that these diseases, which are vaccinated against, can cause problems because they've not seen it in their lifetime. And I think probably getting across to combat these people would be a good thing to do. We may already be doing it, and I'm sure Jonathan will tell me if we are. But measles is coming back big time. I know we don't, scurvy you don't vaccinate for, it's a diet thing, but scurvy is now a problem in large parts of London because of the diet. And a lot of it, as I said, is to do because people now haven't seen that in their lives in the past. And, we should be getting some sort of education out there as it was in the 60s. In the 60s, you wouldn't dream of not vaccinating your children. And in the 70s, but some people tend to do that now. And I would say as well, when it comes to obesity, and I think I can speak from personal experience here, I have lost weight in the past, but immediately put it back on again. And my current GP doesn't apply to, but I have to say, Councillor Dudley, I've gone into my GPs before who say, you need to lose weight. Bye. If I walked in and said I've got a drink and drugs problem, they won't say you need to give them up. Bye. There just doesn't seem to be that help or as much with obesity, although it's a huge problem. Luckily, touch wood, I haven't got any health conditions related to obesity, other than I get asthma, and it's probably a contributing factor. But I think there needs to be more help for people to go, do you know, I've got a problem with my weight. What do I do? Lose weight. That's not helpful. Okay.
Okay, Jonathan. Yeah, I think there's a few questions in there. Yeah.
Thank you, Councillor Carr. You're bang on the money about vaccinations and immunisations, and the hazard that exists when rates become very low. And you're quite right, in London in particular, and some other big conurbations, the low rates of vaccination against measles, mumps and rubella represents a real risk to the population. So it is something that we're working hard on in Nottinghamshire, and you're right to highlight that we're challenged here as well. And as ever, the county level data masks an enormous amount of variation. So it's one of the other things which is moving from an NHS regional responsibility back to Nottingham and Nottinghamshire. And I think, again, one of the opportunities that provides to us is to make sure that there's a really sharp focus on inequalities and where there's greatest unmet need. Thank you for highlighting some of the opportunities as well around overweight and obesity. And I'm pleased that the council continues to fund the commissioning of what we call an integrated wellbeing service to support people who want to take some action around tobacco or indeed alcohol or physical activity and overweight. Be pleased to make that information available to you or indeed to anyone. I was fortunate to go along recently and to attend one of the sessions they were running for some residents up in Ashfield, and was very pleased just to find how engaging the person leading that session was, and the kind of continuity and commitment that he'd been able to secure from the residents attending. So I can recommend it to you and to other residents. Happy to provide information.
Thank you, Jonathan. Thank you. Yes, I think anything we can do to help with prevention and help with people's lifestyles is very important. As a council, we can do that. Good. If there's no other questions, I believe, Jonathan, it's your last meeting with us. Is that right?
I think it will be. Yes.
So, on behalf of this committee, may I thank you for all the work you've been doing as Director of Public Health for the County Council. I know you guided us through the COVID pandemic, with a lot of pressure of you at that time. And we thank you for all your hard work during that, and wish you well in your retirement. Okay, I asked Martin just to go through the recommendations, but we will actually do a little bit of research in the licensing councils and the district council what the actual remit is for vaping within pubs when they get the license and things like that. So that's something we can research.
If I can interject there, what funding they will need to be able to do it.
Sorry?
And what funding they would need to be able to do it.
Well, it would come part of the licensing
yes.
recommendations, wouldn't it? When somebody applies for a license, it would be a part of that.
Just briefly, ask who gave Jonathan permission to retire.
Probably his wife.
Legislation.
Thank you, Martin. Sorry.
Yeah, so I'll just read the first two out just to be so we know exactly what we've got. So that the factors which have the greatest impact on the health and well-being of the population, and that when these building blocks are weak or missing, healthy life expectancy is reduced and inequalities increase, be noted. That the areas of work required to address a minority of outcomes where Notts is worse than England average are largely identified in the Nottinghamshire Plan and the Joint Health Wellbeing Strategy. That be noted. That we get some further information on the regulations around vaping indoor spaces where smoking is not allowed, and that is circulated to members of the committee. And then just the areas for further scrutiny. It's highlighted in the report. If I can scroll properly. That the areas for possible future work are inequalities in women's and children's health, and that includes areas that around life expectancy and healthy life expectancy. So that will include obesity, and then also it's recommended about substance use, which includes the harms of drugs and alcohol, especially with those having multiple disadvantages. I think obesity, from the discussion and previous discussions with Jonathan, I think obesity factors into all of those. And then there was some discussion about vaccination levels. I know that's a little bit complicated about what we actually do have responsibility for. But if we list all those items, and then the chair and vice chair can then discuss with officers how you can best look at those in more detail. Is that fine? Is there anything else that anyone else would like to look at in more detail?
With those recommendations,
Sorry, Chair. Are we looking at the inequalities side of provision as well?
Yes.
Yeah. Okay. Thank you.
The recommendation been approved and seconded. All those in favour? That's unanimous. Thank you very much indeed. I'll ask Martin now just to go through the works programme, please.
Yeah. So the work programme is just to note, probably the one to draw your attention to, that the review of how the day opportunity strategy has been implemented, that starts this afternoon. So that's at 2:30. So that the members will be meeting today, and then there'll be a second meeting. I think it's the week before Christmas, which is on the 18th. And just as usual, if there's anything you'd like to look at, please let myself and the chair know, so we can look into that further, and also keep your eye on the forward plan in case there's anything on the forward plan that you feel either you'd want more information on, or that you would like to get some scrutiny on.
Thank you, Martin. Anybody any comments on the work programme? If not, we'll move it, note it. Thank you very much. That brings us to the end of the meeting. I thank you very much for your attendance and input, ladies and gentlemen, and also for the officers coming on as well for their help and input on the meeting. So I declare the meeting closed. Thank you very much.